So hi, I'm Dr. John Snider. I'm a neurologist with VCU with a specialty in movement disorders, so Parkinson's and all of its mimics. I'll be talking to you about cognitive and behavioral changes in these conditions, which is a very broad topic to cover in 15 minutes, so I'll kind of touch on the highlights. So we'll be talking about what the common cognitive and behavioral changes you see in Parkinson's and its various mimics like PSP and corticobasal and Lewy body. When should you evaluate? If you notice that you're having some cognitive or behavioral changes, when's a good time to get it evaluated? And then what do we do about it? When we have these cognitive and behavioral changes in these conditions, how do we evaluate them as physicians? How do we treat them, both in general and then with a little specific emphasis on some of the psychotic symptoms that people can sometimes get in these conditions, hallucinations and such. So what are common cognitive and behavioral changes you may see in Parkinson's and Lewy body disease and Lewy body dementia? Commonly things like short-term memory problems such as forgetting appointments, misplacing things, or forgetting conversations, visual spatial issues, getting lost in familiar places, executive dysfunction, kind of advanced planning or planning multi-step things like following multi-step directions, trouble managing finances and keeping up with shopping lists and bills. Just as a definition, if someone has cognitive problems or memory problems, but those problems aren't enough to limit your day-to-day activities, we call that mild cognitive impairment. And actually, it's pretty common in Parkinson's patients. About 30% of Parkinson's patients will have this mild cognitive impairment, enough memory issues that aren't bad enough to get in the way of things, but that are present about 30% of the time at the time of diagnosis. And after 5 years, about half of Parkinson's patients will have some degree of memory problems, even if they're not limiting their day-to-day activities. If the memory problems are enough to get in the way of day-to-day activities, we call that dementia. So when you say dementia, it just means the memory issues are enough to get in the way of some of your day-to-day activities. 30% of all Parkinson's patients at a given time will have some degree of dementia. And many Parkinson's patients will develop it at some point during their lives. About 60 to 80% of Parkinson's patients will develop some degree of dementia at some point in their lives, though usually not until many years after initial onset. And again, that can range from anywhere from mild to more severe based on the person. We do differentiate the two, Parkinson's dementia that you'd see in Parkinson's disease versus the dementia you see from Lewy body dementia, and differentiating those two conditions, mainly based on the time course of when the memory and cognitive changes began. In Lewy body dementia, usually the memory problems get severe or are particularly noticeable either before you see the movement symptoms or within about a year of the movement symptoms starting. If that's the case, it usually ends up being Lewy body dementia. If you've had Parkinson's symptoms for more than a year and then you start to develop memory issues, we usually say it's more of a Parkinson's disease dementia or Parkinson's disease memory problems. In either of these conditions, you can also see other symptoms as well, like hallucinations or behavioral changes, in addition to memory and cognitive changes. And just a note, for people with multiple system atrophy, another Parkinson's mimic that we touched on earlier, usually it doesn't affect memory and cognition significantly. There is a small percentage of patients that we're seeing maybe are affected, but usually they're not as significantly affected if you have multiple system atrophy when it comes to cognition. How about some mood symptoms can also be seen in these conditions. Depression is very common, and not just, oh, I'm feeling bummed out because I have these conditions, but actually due to brain chemical changes from the underlying diseases causing depressed mood and depression. Classic symptoms: you lose interest in things that you used to like to do, you lose enjoyment in things you like to do, you may feel sad, have changes in sleep or appetite, sleeping or eating more or less. You may find that your concentration or your memory or your energy is worse as well. And again, a lot of different things can cause you to maybe have poor sleep or poor energy or memory and such. But if you start to see these symptoms, it does make me want to explore, how your mood's doing. If depression is severe, it can actually contribute to or even cause things like hallucinations or other behavioral changes. So it can be very relevant in a lot of different ways. It's not uncommon at all for Parkinson's patients to develop anxiety. Sometimes this can even be a wearing off effect of your medication. When the medication wears off, you get very, very anxious, and when your medication's working, that anxiety subsides. And apathy, very common in these conditions, kind of just losing your get up and go, kind of being a lump on a log, just not having a whole lot of, get up and go and gumption. and you kind of have to be dragged off the couch, and then once you are, okay, we'll do it, but you just may not have that get up and go. Rarely, patients who are on some Parkinson's medications can also develop some odd side effects like compulsive behavior and hypersexuality that usually isn't as associated with the disease itself, but sometimes can be a rare side effect of medication. How about in other Parkinson's mimics, cognitive and behavioral changes in progressive supranuclear palsy, PSP, or corticobasal degeneration, CBD? A lot of times this presents like someone who has a condition called frontotemporal dementia. So kind of losing your filter, losing you get disinhibited is very common. You may notice inappropriate behavior, being very impulsive. Sometimes you can see some hypersexuality. Apathy, again, common here. Kind of just exercising poor judgment, not having the same good judgment that you did before. You may notice poor hygiene or poor diet, overeating, really overstuffing your mouth, piling way too much food in your mouth, and you say, whoa, 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 slow down. Again, you're losing you're disinhibited. You're more impulsive. You may be kind of indifferent to symptoms that everyone else thinks are pretty severe, and you just are pretty indifferent too. You may notice some language problems, either trouble getting words out or trouble understanding words coming in. A symptom called pseudobulbar affect, or emotional incontinence, basically laughing at things that aren't funny, crying at things that aren't sad, laughing for no reason, crying for no reason. Generally speaking, with PSP and corticobasal degeneration, memory is relatively spared. It tends to be more these frontal behavioral things, less so memory, as opposed to in Parkinson's disease and Lewy body dementia, where memory is more prominently affected. So when should you seek evaluation for this? I mean, we all forget where we put the keys or forget a conversation we had with our spouse last week, perhaps selectively. So when should we look into this more? So there's no specific right or wrong time to get it looked at, but I think these are some situations where you should certainly consider mentioning it to your doctor. Certainly if you or your family or friends or your doctors notice changes and are concerned about them. If you talk to your friends and say, oh, I forgot where I put my keys this week, and your friends are like, oh yeah, I'm having the same exact problem, it may just be something that people your age are going through. But if you find that your problems are more than what your friends your age are experiencing, that may be a clue to get it looked at. And certainly if any of the cognitive or behavioral changes are bothersome or are keeping you from doing stuff or even dangerous to you or others, you should definitely get that looked at. I will say a lot of times family and friends and doctors notice these changes before patients do. And sometimes in these conditions, patients don't notice the problems at all and will frankly deny that they're having any issues. And to that, I would just say to patients, give your family the benefit of the doubt that a lot of times they may notice things that you may not. And so if other people are commenting on this, take it seriously and give them the benefit of the doubt there that they may be noticing something that you're not. So how do we as physicians evaluate cognitive and behavioral problems in these conditions? Well, your doctor should do a very detailed history and exam, which may include some memory testing at the time. Your doctor will probably look for other reversible causes, other things that could be affecting your cognition outside of these diseases. Do you have a urinary tract infection? Is your sleep really terrible? Are you depressed? Are you on medications that could be affecting your cognition or behavior? Could there be other medical problems like vitamin deficiencies or thyroid problems that could be either contributing or causing these problems? Your physician may want to get more detailed memory testing to help gauge where your strengths are, where your weaknesses are, and if there are weaknesses, how to work around them. And if there are weaknesses, is there a pattern that could suggest what it's from? Is it from your mood? Is it from your underlying condition? That sort of thing. Oftentimes we'll get some head imaging like a CAT scan of the head or an MRI scan of the head to make sure there's no old blood or lumps or bumps or shrinkage in a way that could give us a little more information. This detailed memory testing can also help differentiate between these various mimics. Sometimes if we're trying to decide if someone has Parkinson's disease or PSP or Lewy body, sometimes the pattern of weakness in cognition can help us point more towards one or the other. So it can be both diagnostic and therapeutic if it's done well. So how do we treat cognitive and behavior changes? Well, first of all, it's important to know that nothing slows down the progression or reverses the course of these diseases. Treatment is symptomatic. If you have symptoms that are bugging you, we do our best to try to keep them from bugging you so you can live your life and do your thing. I would suggest always to exercise your mind, just like in Parkinson's and its mimics. It's important you're exercising your body. Make sure you're staying mentally active as well, having conversations with friends, reading a book, doing crossword puzzles or Sudoku, being active socially. Just keep your mind active as well. It can be very beneficial. You could consider seeing a cognitive disorders specialist or even consider a memory-enhancing medication. Now, these memory-enhancing medications may provide some benefit, particularly in Parkinson's disease dementia or Lewy body dementia, but it's important to keep in mind there's no magic bullet medication when it comes to cognitive disorders. These things can be helpful, but again, it's not a magic bullet. Some of the studies that we say, well, what's the benefit of it, is that it kind of holds things steady for a time. It kind of, however your cognition may be worsening, it kind of holds it steady for maybe 3 to 6 months at a time, and then things progress however they were otherwise progressing. Now, in some of these conditions, like in Parkinson's disease dementia and Lewy body dementia, it may even do a little bit more than that. Some people tell me not just, oh, I feel the same, which is the idea, it's supposed to hold things stable for a time, but they may actually say, you know what, I feel a little sharper. I feel like, you know, feeling a little bit better. Maybe my thinking's a little bit better on that. And we do see that sometimes. But the main thing is it's supposed to try to hold things steady for a time. People who have memory problems who are on this probably do better than people who have memory problems and aren't on this in Parkinson's disease dementia and Lewy body dementia. And these are some of the various medications. There's donepezil, also called Aricept, rivastigmine, Exelon, galantamine. There's a medication called memantine, also called Namenda, which is used in Alzheimer's disease. Evidence is weak that it helps in Parkinson's disease memory problems or Parkinson's mimics. Sometimes people will prescribe it because there's some weak evidence. You know, the jury's still out on whether that one is helpful in these memory conditions. And if people have that pseudobulbar affect, the laughing for no reason, crying for no reason, and it's bothersome, there is actually a medication you can take to help quiet that down called Nudexta. So again, if you have bothersome symptoms in that regard, we have ways of helping with the symptoms, even if there's not magic bullets. In terms of the mood symptoms, which can be just as bothersome and disabling as the memory symptoms, it's important these are treated too. So with depression and anxiety, you could consider talk therapy with a social worker, psychologist, or psychiatrist. You know, continue to exercise, work on control of your Parkinson's symptoms. People tend to be in better moods if their other symptoms are under better control. You could consider an antidepressant or anti-anxiety medication. And again, in mood symptoms in these conditions, a lot of times it's because you don't have enough of the mood chemicals in your brain. So remember, in Parkinson's disease, you don't have enough of the movement chemical dopamine. Well, a lot of times you also don't have enough mood chemicals. So just like you take some carbidopa, levodopa, cinnamate to kind of supplement the dopamine, have some extra movement chemical, these antidepressants or anti-anxiety medications can kind of be you know, extra mood chemical, just to kind of get things back to where they should be. You certainly want to monitor, you and your family should monitor for symptoms of things getting severe, of that depression or anxiety really getting bad. Certainly if you have thoughts of hurting yourself or hurting others, you should really let your family and physicians know. And if they're present and severe, or certainly if the family's concerned, you know, if the patient's at risk, have a low threshold to call 911 to you know, get their mood feeling better if things are very dangerous for them. With apathy, the losing the get up and go, you know, try to keep scheduled activities. I like to say keep a calendar. You know, don't just say, oh, we should go to the pool sometime today. Say at 3 o'clock, we're going to the pool. It's on the calendar. Let's do that. It kind of helps get things a little more regimented, get people moving a bit more. Other kind of good advice for cognitive and behavioral changes, definitely consider future planning, basically to get ahead of things and make sure that things are safe and well managed at home. Again, our goal whenever someone has memory problems and cognitive problems is to maximize your independence and maximize your safety, and just trying to find a balance between the two. We want you to be as independent as possible, but also as safe as possible to make sure you have the resources and support to make that possible. Getting a designated power of attorney early is worthwhile. So if you develop memory or cognitive problems or other problems that are enough that they're keeping you from making decisions, you have someone who you've kind of chosen ahead of time and is legally noted to be able to help make those decisions for whatever period of time you're not able to make sure that your wishes are honored for finances or medical decisions, etc. You should definitely discuss ways to focus on safety and make sure you have adequate assistance and supervision at home so you can, again, be as safe as possible but as independent as possible. Perhaps if you're having trouble managing your medications, have a family member double check it for you. If you're having a little trouble with bills sometimes, maybe have them double check your math. Certainly keep an eye on your driving. My general rule of thumb is if there's any concern about your driving from anyone, you or family members, I usually recommend either not driving or doing a either occupational therapy driving safety evaluation or going to the DMV and getting a driving evaluation there to make sure that you're safe on the road. Again, we want to focus on safety here, and I want to make sure that you're driving in situations where it's safe and you're not at risk for yourself or others. Again, balancing that independence with safety. Sometimes people could benefit from having an additional hand at home. If your spouse works or is out during the day, having someone else around to help you out during the day may be useful, etc. Just thinking about ways of kind of managing things on a day-to-day basis, making it easier for everyone. Support groups and even day programs can give you something to do, get you out, and also be a fun opportunity. It's important that caregivers know they need to take care of themselves if they're going to take care of the patient. So make sure as a caregiver that you are able to have some time to yourself, that you're able to get sleep, that you're taking care of yourself as well. Don't be a martyr. You know, it's important that you're taking care of yourself. And some patients do eventually require higher levels of care than you can get at home. You know, my goal is to keep people at home in the environment they want to be in for as long as possible, but sometimes you need an extra hand, and things like assisted living or other type places may be useful and beneficial to keep people, you know, safe but also, you know, relatively independent too. And then one last word just on a particular topic, psychosis in Parkinson's and its mimics. Psychosis is basically losing some degree of contact with reality. That can manifest as hallucinations, seeing or hearing things that only you can see or hear, delusions, which are things you absolutely believe are true that are not, but no one can convince you otherwise, or paranoia, a feeling that people are out to get you. Again, not everyone gets these, but they can be common symptoms and they are treatable if they're bothersome. So how do we treat psychosis? Well, again, the first rule, generally speaking, if it's not bothersome or dangerous, it's usually okay to observe. If you have a hallucination of your granddaughter by your bedside and it's comforting and you know it's not real and it's not bothersome, it's okay sometimes to just keep an eye on that, not specifically treat it. It's important you let your doctors know, but it's okay sometimes to monitor it if it's not bothersome. Sometimes just gentle redirection by your caregiver. Actually, you know, honey, there's not a dog outside the window, or, you know, that person's not here at the moment. Oh, okay, gotcha. Can sometimes be helpful too. Obviously, we look for reversible causes, just like we talked about. Make sure someone's medications aren't contributing, or that they don't have an infection, that they're not depressed, or there's not another medical illness that could be contributing. Sometimes if the hallucinations or the psychosis are getting bothersome, if you're calling 911 or swinging at them or getting scared by it or frightened, if it's bothersome, we may need to make some adjustments in medications. We may actually either decrease or adjust some of your Parkinson's medications, because sometimes those can contribute to hallucinations and psychosis. So you may find we adjust it or dial it down a little bit. Sometimes there are some antipsychotic medications that at gentle small doses can be helpful. Now, the problem with antipsychotics is a lot of them work by blocking dopamine. And what's the big problem in most of these conditions? You don't have enough dopamine already. So a lot of the normal antipsychotics we may use in someone who doesn't have Parkinson's or one of these mimics and who's having hallucinations, we can't really use here because they're going to worsen the Parkinson's symptoms. Now, there are some antipsychotics that tend not to worsen Parkinson's and are safe in these conditions. Quetiapine, Seroquel is pretty easy to use and pretty effective. There's one called clozapine that's quite effective, but it's a little bit of a pain in the butt to use because you have to do weekly blood monitoring, and so that requires a bit more legwork. And then another one, pimavanserin Nuplazid, which is specifically for Parkinson's disease dementia, takes a few weeks to kick in, but can also be probably as effective as Seroquel, quetiapine. A couple words on that one. I don't like their commercials at all. You've probably seen them on TV. I think those commercials are not representative of the experience, and I think are a little fear-mongering. And there has been some reports in the news about whether pimavanserin can be associated with increased mortality and death in people who are older or who have dementia. I think that when they've done the studies so far, we haven't seen any increased rate of that compared to other antipsychotics. When people are on antipsychotics, there is an increased risk of mortality in the studies, but that probably has to do with the fact that the people who need antipsychotics probably are a bit sicker anyway, as opposed to that the antipsychotics are markedly risking your life. And again, we only use medications if we need them, and sometimes these can be very useful, and the benefits certainly outweigh the risks in the right patient. oftentimes, if things are getting more bothersome, seeing a psychiatrist or a geriatric psychiatrist, as well as a social worker for specialized care, can give you that extra level. And again, sometimes those memory-enhancing medications that I mentioned earlier have been shown to actually stabilize hallucinations in some cases. So maybe the hallucinations are a little bothersome, not too bad. You don't want to start an antipsychotic at this point in time. Maybe start one of the memory-enhancing medications, and sometimes those can, as a side benefit, settle down hallucinations a bit. All right, thank you very much.